Miscarriage. What is miscarriage? According to definition, spontaneous loss of pregnancy before period of viability. And what is period of viability? According to Royal College of Obstetricians and Gynecologists, if a baby delivered before 24 weeks, and according to WHO, if a baby delivered before 28 weeks or baby weight less than 1 kg, then this is called miscarriage. And new definition is 22 weeks, or if the fetal weight are less than 5 gram, then it is called miscarriage. So in all miscarriage, in all pregnancy losses from the time of conception until 24 weeks. Type of miscarriage: sporadic miscarriage, inherited risk of miscarriage, 15% incidence. Recurrent miscarriages, recurrent miscarriages, 3 or more consecutive miscarriages, 1% incidence. Types of recurrent miscarriages: primary without previous live birth, and secondary with previous live birth. Risk factor for recurrent miscarriage: some factor and maternal body that is persistent or recurrent. Most common unexplained or idiopathic, 50%. Among the known causes: APLS, antiphospholipid syndrome, most common, it is 15%. Uterine abnormality and cervical weakness, second most common, 1.8 to 33.6%. And endocrine factor: untreated diabetes mellitus, thyroid dysfunction, PCOS, polycystic ovarian syndrome, and inherited thrombophilias, especially factor F5 laden mutation, proton bean gene defect, and protein S deficiency. Infective agent: bacterial vaginosis, parental chromosomal abnormalities, least common, 2 to 5%. Two independent risk factors: advanced maternal age. If maternal age are greater than 35 years, then chances of recurrent miscarriage are increased. In previous number of miscarriages, advanced maternal age is associated with decline in both number and quality of oocyte. Lowest risk between 20 to 29 years, it is 12%. Greatest risk when age greater than 45, it is 93%. Advanced maternal age is also been identified as a risk factor for miscarriage. The risk is highest among couples for women greater than 35 and men greater than 45 of age. Previous number of miscarriage: risk of further miscarriage increase after each successive pregnancy loss. After one previous pregnancy, risk of repeat miscarriage 15%. After previous two miscarriage, risk of repeat miscarriage 25%. After previous 3 miscarriage, the risk of repeat miscarriage is 40%. After previous 4 miscarriage, risk of repeat miscarriage is 50%. Antiphospholipid syndrome: the most important treatable cause of recurrent miscarriage. APLS is a form of acquired thrombophilia. The referred to as between FLA and adverse pregnancy outcome or thrombosis. Diagnostic criteria: so for criteria required: presence of one clinical plus one lab criteria. Clinical criteria is true vascular thrombosis, adverse pregnancy outcome, 3 or more miscarriages before 10 weeks, 1 fetal death of morphologically normal fetus after 10 weeks, 1 or more preterm birth before 34 weeks, usually due to placental disease, preeclampsia, ER. Lab criteria: the father tests at least 12 weeks effort for either lupus anticoagulant, anti-calcium antibody, anti-B2 glycoprotein antibody. Mechanism of pregnancy loss and APS. APLA causes inhibition of thromboplastic function and differentiation, activation of complement pathway, maternal fetal interface, resulting in local inflammatory response, thrombosis of intraplacental vasculature leading to miscarriages, IUD, IUGR, preeclampsia. All these effects are reversed with aspirin and heparin. If left untreated, rate of live birth in APDS is only 10%. If treated both aspirin and heparin, 70% live birth rate. Whom should be screened for APLA? All women with recurrent first trimester miscarriages and three or more than three, they should be screened, and all women with equal or greater than one second trimester miscarriage should be screened for APLS. Investigation two positive tests at least will be referred for either lupus anticoagulant, anticoagulant antibody, anti-B2 glycoprotein antibody, LAC, lupus anticoagulant most productive of thrombosis, ACL most predictive of adverse pregnancy outcome. Treatment of APLS. Low dose aspirin and heparin should be considered for treatment to prevent further miscarriages. For preconception, start folic acid. Upon urinary pregnancy test positive, start low dose aspirin, and if cardiac activity are positive on ultrasound, start low molecular weight heparin or clexine. Monitoring for complication, DVT, preeclampsia, UGR. Uterine abnormalities prevalence second most common 1.8 to 37.6% is high among women with second trimester miscarriages than first trimester miscarriages. Types congenital separate uterus first trimester miscarriage most common, arcuate biconvate second trimester miscarriages. If implanted, chances of live birth. If implanted, 50% required fully provide achievement in pregnancy with provide rate of miscarriages 14%. Whom should be screened? All women with recurrent first trimester miscarriage and all women with one second trimester miscarriage initial screening test, 212 ultrasound, 2 ultrasound or HCG. Definitive diagnosis combine hysteroscopy and laparoscopy. Ultrasound rule of MRI screening remain undetermined. Treatment: metroplasty, reconstructive surgery. No published randomized trial to assess the effect of reconstructive surgery and preventing further miscarriages. It should be evaluated in child. Cervical weakness. Recognized cause of second trimester miscarriage. True incidence is unknown. Diagnosed is clinically 1. History of two miscarriages preceded by spontaneous rupture membrane or finally cervical dilatation. Cervical length. If cervical length is less than 25 mm before 24 weeks of gestation, funneling of the cervical canal, lower length rotation. Treatment: cervical circulage. History base: 3 feet on labor, not trimester breaches, and 14 weeks. Ultrasound base: 1 feet on labor, mid-trimester. Cervical length to 25 mm before 24 weeks, started from 2 feet and wide anytime from 25 mm. Hurricane cervical dressing. You may see the figure of the cervical circulage. And these are the pictures. Endocrine factors. Anti-diabetic mellitus thyroid dysfunction or risk factor for miscarriage. How will control diabetic mellitus and thyroid function? This is not a risk factor for recurrent miscarriage. Disease increase the risk of miscarriages, increase insulin resistance, hyperinsulinemia, and hyperandrogenemia. Elevated pre-androgen index for the miscarriage. Recurrent miscarriage. LH separation in PCOS in ovarian treatment does not involve live birth rate. Evaluate preventing. Later, due to the specific results in first trimester miscarriage, there is rule of progesterone and HCG supplementation in recurrent miscarriage. A large multi-center study currently underway to assess its role in pregnancy of unexplained recurrent miscarriage. And thrombophilia cause of recurrent miscarriage by causing thrombosis of uteroplacental circulation responsible more for late recurrent miscarriage, late recurrent losses, early pregnancy losses, whom should be screened. Women with second trimester which second trimester should be screened for it, including risk 5 laden and prothrombin gene mutation and protein insufficiency. These strong as between second trimester at treatment. Heparin improved life birth rate and women with second trimester missing insufficient weight and effect of heparin increase miscarriages, recurrent and relapse. Chromosomal abnormality. Parental chromosomal abnormality least common cause in about 25% of the problem. One of partner carries a balanced chromosomal abnormality, most commonly most common reciprocal translocation, which causes unbalanced chromosomal abnormalities in uterus. Diagnosed phenotyping are part of conception. If reported unbalanced chromosomal abnormalities, then cerebral blood. Both partners should be used for cytogenic analysis, treatment, pre-implantation genetic screening, and IVF as the only treatment option. Embryonic chromosomal abnormalities increase with decrease in maternal age. If recurrent miscarriage, embryonic chromosomal abnormalities accounts for 30 to 57% of the further miscarriage. Most common chromosomal abnormalities is triploidy. Infective causes. Torch is not responsible for recurrent miscarriage. It causes only sporadic miscarriage. Bacteriogenosis is responsible for second trimester miscarriage and preterm delivery, but not first trimester miscarriage. Evidence shows treatment of bacteriogenosis in second trimester with oral clindamycin significantly reduce the incidence of second trimester miscarriage and preterm delivery. So a positive should be treated. Unexplained recurrent miscarriages. Women with unexplained recurrent miscarriage have an excellent prognosis for future pregnancy outcome without pharmacological intervention. If upper supportive care alone in the region and 75%, however, prognosis worsen with increased maternal age and number of miscarriages. To recent RCT does not support rule of unexplained recurrent miscarriage. Data suggests that the use of empirical treatment is women with unexplained recurrent miscarriages is unnecessary and should be resisted. Uterine anomaly causes recurrent first trimester miscarriages, arcuate uterus, biconjugate uterus, separate uterus, cervical incompetency. Most common known cause for recurrent miscarriage: epilepsy, uterine anomaly, thyroid dysfunction, PCOS, polycystic ovarian syndrome. Common chromosomal abnormalities causing recurrent miscarriages: ribosome translocation, reciprocal translocation, trisomy, and malformation. Most predictive of adverse pregnancy outcome: ileus, lupus, and anticoagulant antibody